And then we have the third eating disorder we're going to talk about today, which is the binge eating disorder. Okay? A criteria, recurrent binge eating. Okay? And we talked about what binging was when we were discussing bulimia a moment ago. But the binge eating episodes are associated with three of the following. Okay? Three of the following, these five. One, eating more rapidly than the average person would eat. Eating until you're uncomfortably full. Eating large amounts even when you're not hungry. Eating alone because you feel embarrassed. And five, associated with this, you feel disgusted, depressed, or guilty about these behaviors. C, this binge eating brings marked distress to your life. The binge eating needs to occur one time per week for a duration of at least 3 months, and it's not associated with compensatory behaviors, right? So we see the real critical difference here between bulimia and binge eating disorder. There's no compensating, so there's no vomiting, you're not taking diuretics or doing excessive exercise. It's the binging without compensating for it. One little interesting tidbit, it's not at the level of disorder, but it's sort of a non-clinical term that's being talked about in some media outlets right now, a term called orthorexia. Orthorexia is being described as a fixation on righteous eating, which is really interesting. People taking healthy eating to an obsessive level, right? So they're not obsessing about the quantity of food, but rather the quality of food, that they'll only buy organic, or they'll, they won't eat certain types of foods. And it's related to sort of, a generally positive epidemic in North America right now to encourage healthy eating, but it's about people who take eating healthy to an obsessive level, orthorexia. All right, a little bit here now about prevalence and just comorbidity and things like that for each of these disorders. On anorexia, the prevalence in adolescents or young adults is 0.3%. It affects 90% of girls. I've seen it said, a 10-to-1 ratio of females to males who have anorexia. They will present as having a reduced weight and some comorbid conditions, bipolar, depression, anxiety, suicide. In general, we can think of very high comorbidity with eating disorders and anxiety and depression. Very commonly go together across all of them. Most people will be in remission after a 5-year period. Okay? Approximately a 5% mortality rate per decade. And bulimia nervosa has a prevalence of 1%, so bulimia more common than anorexia, significantly more common. Around 2% mortality per decade. And usually normal weight, they present as having a normal weight. Comorbid conditions, we see depression and anxiety again. Bulimia can be chronic or intermittent with periods of remission, but then it usually starts up again. Binge eating disorder has a prevalence of 1.5 to 3%, so arguably the most prevalent of the three that we've been discussing. More girls than boys affected, but not to the extreme degree as we see here, where it's so predominantly females. It's not as pronounced in binge eating disorder. These individuals may present as normal, overweight, or obese, and it can also be sort of chronic or intermittent with periods of remission, but then coming back to it. And comorbidity similar to the others with the anxiety and the depression. And finally, a little bit about etiology and developmental course. The peak onset, they're kind of in order here. So anorexia has the earliest onset, typically early adolescence, so thinking things like your 12, 13-year-old. Mid to late adolescence is bulimia, so now we're talking things like 15, 16, 18 years old. And late adolescence, 18, 19, 20, 21, the onset of binge eating disorder typically. What's the etiology look like? There's actually not a ton of emphasis on the particulars of the genetics of eating disorders. It's very complicated, and a lot of work is being done right now on that. But it is considered to be a set of disorders with high heritability. So if you have a parent who has an eating disorder, you're at an increased risk. If you have a sibling with an eating disorder, you're at an increased genetic risk. But there are some sort of child-based or temperamental characteristics that can be risk factors for developing an eating disorder. If you are someone who has a high anxiety temperament, if you show obsessional traits, if you generally demonstrate negative emotionality, perfectionistic tendencies, which is sort of a specific form of obsessive behaviors, emotion dysregulation, which makes sense, right? So if you're not able to regulate and cope with your different emotional states in healthy ways, you might turn towards these disorders to be sort of coping mechanisms. And a low sense of agency is an interesting one. So you've probably heard of eating disorders talked about in this way that people who feel that they don't have control in their life can take control over this domain, that they can be fastidious over controlling what goes in and out of their body and how much they exercise. And so this trait of having a low sense of agency or volition is associated with a higher risk for an eating disorder. Environmentally speaking, there are certain cultures and settings where thinness is valued more. In those cultures, there's an increased risk. Even beyond different ethnic cultures, we can be talking about certain settings. So for example, there's an increased risk if you work in the fields of modeling or elite athletics. If there's family dysfunction or conflict, that is a risk factor, although it's not as strong of a risk factor as if you, as there would be if there are critical comments coming from mothers and fathers, but mothers in particular is a risk. So critical comments about appearance or don't eat that or you need to go on a diet and things like that. Maternal modeling of unhealthy eating habits or of dysfunctional eating habits is a risk factor. So if your mother, who is your primary female role model when you're a female, oftentimes that can be detrimental. Paternal rejection, being rejected by your father in some way, being teased by your father about your appearance. Peer influences, certainly, and what's sort of the norm in your peer group in terms of popularity and attractiveness and how you're supposed to look in your peer group. Negative life events can be a trigger, and also media influences. So the biopsychosocial model really works well here. So the bio in terms of the genetics, the psycho in terms of the child or temperamental characteristics, and then the social in terms of our environmental list here. That's all, folks. See you tomorrow. Bye.